Hello friends, today we'll be discussing a topic of benign prostatic hyperplasia, and along with that we'll also discuss a clinical scenario, that is a 60-year-old man presenting with difficulty in micturition and increased frequency of micturiation at night time. So how will we manage these patients, and how will we investigate and manage this patient? This question has been asked in undergraduate these days for MBBS final year exams and surgery, and along with that for MS and DNB final year exams. This will be helpful, and also for NEET PG students for the basics, it will be helpful. Basics of urology. So, without further delay, we'll start. Before starting, I would like to thank Chandana Shri Ma'am for sharing these wonderful notes with us, which are very helpful for quick revision. So, let's get started. The link for the notes is given in the description below. You can download it from there. So, benign prostatic hyperplasia. Before going, we'll go for the anatomy. So, anatomy of the prostate. So, prostate has various zones, that is the peripheral zone. Then we have a transition zone and a central zone. And anteriorly is the anterior fibromuscular stroma. So the peripheral zone is known to cause cancer or gets converted to cancerous tissue. The transitional zone is known to cause hyperplasia, that is benign prostatic hyperplasia. So as you can see in the diagram, there is a pre-prostatic sphincter that is just in the bladder neck, and below after the prostate is the external sphincter, and centrally there is a urethra passing. What is the arterial supply of prostate? It is through the inferior vesical artery, and it gives rise to prostatic artery and urethral artery and capsular arteries. Venous drainage is through the prostatic plexus, which communicates through the Bateson's plexus, and later it goes into dural sinuses, and lastly the internal iliac nodes where the lymphatic drains from the prostate. Now coming to the physiology. So hypothalamus, that produces LHRH, LH releasing hormone, in a pulsatile manner, which acts on the pituitary, giving rise to LH, and these LH stimulate the Leydig cells of the testis, which gives rise to testosterone. Testosterone acts on prostate. Testosterone also gets converted to 1,5-dihydroxytestosterone, which also has trophic effect, which is over 5 times more. So when we give estrogenic steroids, or when the body creates estrogenic steroids, it has negative impact on hypothalamus. So LHRH's production is affected. If continuous LHRH analogs is given to pituitary, it stops producing LH. Orchidectomy will affect the testis, so testosterone will not be produced. And 5-alpha reductase inhibitors will inhibit 5-alpha reductase, so testosterone will be not produced to dihydrotestosterone, so the effect will be reduced on prostate. This 5-hydroxytestosterone is present in prostate itself, perigenital skin, so it will reduce the growth of prostate. So overall, we have to reduce the growth of prostate by some of the other means. So now coming to the epidemiology of BPH, that is, it is common in old age patient. It is seen as around 50% in 50 to 60 years of age group, and after 80 it is common as 90%. Idiopathogenesis, that this disease is multifactorial. So along with endocrinal control. So as aging occurs, there is decrease in androgen and increase in estrogens. So that will have direct effect on the prostate and the epithelium, which will cause hyperplasia, causing enlargement of the transition zone. So this will cause compression of the peripheral zone, which forms the surgical capsule and helps in enucleation of the BPH. So this enlargement of the prostate causes obstruction to the bladder outlet, causing mechanical obstruction and functional obstruction. Mechanical obstruction due to intrusion into the bladder neck and the urethral lumen, and functional obstruction through the prostatic stroma smooth muscle, causing increase in the sympathetic tone and increase in the tone of the prostatic urethra. Then secondary bladder response, bladder detrusor hypertrophy and collagen deposition, causing overactive bladder and decrease in bladder compliance. Overactive bladder causes irritative voiding symptoms. Now coming to presentation, and especially for the undergraduates, as they have been asked as a clinical case. So these are bladder symptoms that were given in the question, that there was difficulty in micturition and increased night frequency. So these are bladder symptoms, or they are also known as lower urinary tract symptom, LUTS. So these LUTS can be divided into two groups, that is obstructive LUTS and irritative LUTS. So irritative LUTS is frequency, urgency and nocturia. So as given in the question, the patient had nocturia and frequency of urine. So these are irritative symptoms. Then we have obstructive symptoms, that is hesitancy, reduced straining. Apart from that, incomplete voiding, post void dribbling and double voiding. One important obstructive and irritative symptom is dysuria, that is difficulty or painful passing of urine. So these symptoms are commonly seen in uh, prostate enlargement. Also, it can be seen in cases with urethral stricture, or it can be also seen in cases of prostate carcinoma, sometimes in the cases of bladder stone and bladder outlet obstruction due to other causes, and sometimes cystitis, urinary tract infection, even that can cause some bladder symptoms. So it has to be evaluated and managed. So coming to a special scoring that is used for prostate, which helps in quantifying the severity of the issue. So there are 7 parameters which are considered here, and each parameter is scored from 0 to 5. So what are these parameters? It is incomplete voiding, frequency of urination, intermittency or hesitancy. So what is frequency is, I hope you can understand that frequency is more number of times you have to go to pass urine. So what is this frequency? So if you have to go every 2 hours, you are within 2 hours of passing urine, then it is called more frequency. Then there is intermittency or hesitancy, that during passing urine, if the urine passage stops and you have to restart passing urine, then it is called intermittency or hesitancy. Then urgency, that once you have felt that you have to pass urine, you cannot stop, otherwise the urine may pass in the pants itself. Then there is weak stream, that means the flow that used to be earlier, the urinary flow that used to be earlier is not same as it used to be. And for having good stream, good flow, you have to strain, you have to apply pressure so that urine can pass. Then nocturia. So nocturia, it is said that if the number of time is more than 2. So if you have to get up more than 2 times at a night, at night time, then it is nocturia. Up to 2 times it is okay. Then we add all these 7 parameters score from 0 to 5. So maximum will be 35 and minimum is 0. So 0 to 7 is mild, 8 to 19 is moderate, and 20 to 35 is severe. So these score 0 to 5, where 0 is like there is no problem or almost minimal problem, and 5 is like very dissatisfied, have to difficulty in more than 75% of the time. Then, so depending on these scenario, we will evaluate our patient. This was about history. Now we come to science. So in science, we have to take care, we have to examine the external genitalia first, whether there is phimosis or any submeatal or meatal stenosis, urethral stenosis, that can be examined from outside. Condition of urethra, you can palpate whether you can feel any fibrosis or stricturous pathway in the penile region, and then you can examine prostate. In prostate, we go for a DRE, digital rectal examination of prostate, and from that we will rule out whether there is any nodularity that will give us an indication of carcinoma prostate. And apart from that, we will be noting the size, that is grades of prostatomegaly, which can be from grade 1 to grade 4. So prostate which is felt anteriorly in the DRE examination, if the surface feels flat, then it is grade 1. If it is slightly enlarged but the examining fingers can reach the top of the swelling, then it is grade 1. If the examining finger is just touching the top of the swelling, then it is grade 3. And if the examining fingers cannot touch the top of the swelling, then it is grade 4 prostatomegaly. Again, we will look for consistency and nodularity, which will help us in confirming, rather suggesting whether there is chance of malignancy or not. Induration, which will help in ruling out prostatitis, and tenderness, which will again be sign of cystitis or prostatitis, to be more precise. Then we'll go for urine analysis to rule out hematuria and infection. Then we will check for KFT, RFT, that is kidney function test, which can be raised because of obstructive uropathy, which needs upper urinary tract imaging in the form of ultrasound examination, because whether the kidneys are normal or they are not normal, it needs decompression and hydration and correction of electrolyte, because obstructive uropathy can be dangerous. Then we come to prostate specific antigen, PSA, which will be helpful to confirm whether there is whether there is chance of malignancy or not. But we have to keep in mind that PSA has to be done before DRE or after at least 7 to 10 days of DRE, because DRE can cause increase in PSA. Normal PSA should be less than 4 nanogram, and in case of malignancy, it will be more than 10. Now coming to the imaging, so ultrasound, AUBP, PVRU is done for the urinary tract. Here we'll see whether there is any chance of obstructive uropathy causing hydronephrosis, or any bladder outlet obstruction causing cystitis, or retained urine, that is pre-void and post-void residual volume, pre-void and post-void volume, residual volume. And lastly, the prostate size, the ecotexture of the prostate, whether there is any distortion of architecture or capsular breach that can be possibly seen on imaging, though it is operator dependent. Then coming to additional examination, that is uroflowmetry, which helps us in assessing how is the flow pattern. Uroflowmetry, if the maximum flow is more than 15 ml per second, then it is normal. And if it is less than 10 ml per second, then we consider it as the obstructive flow. So if it is less than 10, then either we have to go for some intervention, or we can start with the medical therapy and reevaluate after some time. Then if whether there is a need for cystoscopy, which can be needed in some cases, if there is no improvement after medical therapy. And lastly, urodynamic therapy, urodynamic studies, which will also give us about the pressure and the flow relation of the patient, and especially will be useful in cases of overactive bladder. Although it is not routinely used, but can be done to further augment the study, though we at least need some form of uh, uroflowmetry or urodynamic study before going for intervention, that will be having as a confirmatory reporting for paperwork. What could be the differential diagnosis? As we have seen for these LUTS features, as we have discussed, it could be cancer prostate, bladder neck contracture, urethral stricture, bladder calculi, UTI, neurogenic bladder, and carcinoma bladder. These can be differentials which can be which have to be addressed in case it is not benign prostatic hyperplasia. Now coming to the management. In the case of mild symptoms, we can always go for watchful waiting, and that will help us in uh, checking whether the symptoms can be managed. Then coming to the medical therapy, which is commonly used. For that, we have alpha blockers. To be more precise, they are alpha 1A blockers. And drugs which we have is tamsulosin, which needs at least 14 days to have its effect. Then we have terazosin, prazosin, daxazosin, which have effects in 7 to 10 days. I would like to mention some extra points like the tamsulosin or these alpha blockers have a side effect of postural hypotension. So these drugs should be started at night time and should be continued at bedtime. That would be better. Also, these can be managed in cases with hypertension because this will cause reduction in BP. And especially in case of normotensive patient, we go for silodosin because it is not having or having very minimal side effect of postural hypotension. So these alpha blockers, what they do, they relax the prostatic sphincter, relax the prostatic urethral sphincter. So from that effect, from that it causes its effect. And there is only functional release of the tract, urethral passage. There is the alpha blocker does not stop the growth of prostate. So the prostate size will continue on increasing even when the patient is on alpha 1 blocker. So it affects the dynamic component. That means the symptoms will improve, but the size will keep on increasing. Also, these drugs, alpha 1 blockers, can also be used patients with PVD, scorpion bite. Then coming to the next drug, that is 5 alpha reductase inhibitor. So these were stopping the conversion of testosterone to 5-dihydroxytestosterone. These drugs are finasteride, dutasteride. So the side effect of these drug is impotence. So we have to be careful while initiating these drugs and have to inform if there is any of these symptoms, then we have to stop the drug. And important aspect is this drug, before this drug acts on the prostate tissue, so it will reduce the prostate size, but it will only act when the prostate size is more than 40 gram. So in case of 40 gram, more than 40 gram, these drugs will have effect. And also to show its effects, it at least needs 4 to 6 months to have sufficient effect which can be noticeable. And these are also useful for alopecia, that is androgenital alopecia. So can be useful for patients with that also. And along with that, it will have its effect on these patients, alopecia patients. Lastly, the dose, tamsulosin is 0.4 mg and finasteride is 5 mg. Then coming to surgical intervention, and these drugs have to be continued for lifelong after it has been initiated, so that there is no further issue of the bladder symptoms. Then coming to surgical intervention, so if there is failure of medical therapy, then we will need surgical intervention. So what are the indication? Urinary retention, refractory to medical management. So we have tried to manage the patient, but the patient is again and again going into urine retention. Urine retention also can be signified as post-void residual volume more than 200 ml. And attempts at catheterization removal is failing. So we, after removing the catheter, if there is urine retention of more than 200 ml or patient is having recurrent urine retention, then we will need surgical intervention. Then recurrent UTI due to bladder outlet obstruction or associated with bladder stone, associated with recurrent gross hematuria affecting the kidneys, that is renal insufficiency, or large bladder due to bladder outlet obstruction. So in these cases, we'll have to go for surgical intervention. One more important thing, before going for surgical intervention, we may have to decompress the bladder if the patient present to us in the form of acute urine retention, and also optimize the patient because these patient can be dehydrated with having some features of obstructive uropathy like increased creatinine and deranged electrolytes. So these have to be corrected before going for surgical intervention. If there is any hematuria, then whether there is need for blood transfusion, that has to be looked out. Then coming to the surgical approaches, so nowadays most commonly is the endourological procedure which is commonly done, and less common are the open surgical procedure. We will discuss both of them. So TURP, that is transurethral resection of prostate. This is the most common one which is done nowadays, and uh, has stood the test of time, where we through the monopolar or bipolar energy we transurethral we resect the prostate. and we have to be careful that the verumentanum should not be damaged and the bladder neck should be protected so that the patient does not have post surgery incontinence. Then in cases of large prostate, we can also go for staged TURP, that is going for a TURP in two stages, because large prostate, if done in a single sitting, can be dangerous for the patient. So stage TURP in an interval period of 5 to 7 days when the patient is physiologically improved. Then next is TUIP, that is transurethral incision of prostate. It is done for posterior commissural hypertrophy or bladder neck elevation due to it. So here we go for two incisions, that is at 5 o'clock and 7 o'clock, just distal to the ureteric orifice up to the verumontanum. Then we have laser for transurethral resection nowadays, that is TUVP, that is transurethral vaporization of prostate, or it is done through laser, that is Nd:YAG, neodymium yttrium aluminum garnet. Then holmium laser enucleation of prostate, that is HOLEP. So these are the laser techniques, laser methods for transurethral prostate resection. And lastly is transurethral microwave thermotherapy that can be used for endourological procedures. Apart from that, I would like to add in the post-op period, we keep the TURP patient especially on irrigation for 3 to 4 days. Also, there is traction kept through the three-way catheter from which the irrigation goes on, and traction is kept for 24 hours so that the bleeding from the prostate is reduced and controlled by the pressure effect of the catheter balloon. So the traction is removed after 24 hours. And after TURP, we have to confirm our diagnosis by histopathology, because sometimes the histopathology may come as carcinoma, so we have to further manage the patient as carcinoma. So histopathology will confirm our diagnosis as benign prostate hypertrophy, because that is the confirmatory uh, histopathological or tissue diagnosis, which is confirmatory. So we always have to follow the biopsy report. And post-operatively, we discharge the patient with antibiotics and flavoxate and analgesics, because flavoxate will help us in reducing whether if there is any chances of overactive or irritative symptoms. It will be sorted with that. And these are muscarinic receptor antagonist, anticholinergics, flavoxate, or among them are solifenacin, etc. Then we have the open surgical procedures, or even now we have robotics for these in these matter. For very large glands like more than 100 grams, or concomitant bladder diverticulum or very large bladder stone, in these cases we go for open surgery, or we may go for robotic surgery. For large gland, we can also go for stage TURP as we have discussed. Then what are the approaches for open surgery? So for open surgery, we have suprapubic, transvesical. When there is a bladder stone or diverticulum needs treatments together, here the bladder is opened and finger is inserted up to urethra. Enucleation is done through the Freer's procedure, Freer's method, and SPC is done. And in Harris method, lateral stitches for the prostatic artery is done. So by these method, enucleation of prostate is done. Then retropubic or Millin's prostatectomy, where anterior prostatic capsule is incised and plane is created and enucleation is done, and bladder neck wedge is removed. And in perineal approach, it is also known as Young's perineal prostatectomy. So this was all about BPH and managing the patients with LUTS. Since in old age, it is the most common cause of LUTS and bladder symptom. So we should consider it as the first differential or first diagnosis and manage our patients in that order. So thank you for watching. If you have liked the video, please like, share and subscribe my channel, and never give up because great things take time, and keep studying, keep growing because knowledge is power. And see you in next video soon. Thank you for watching.